All right, in part four, we're going to talk about the second generation antipsychotics, the dopamine, serotonin 2A blockers, but also talk a little bit about some of these newer medications that may be coming out in the near future. So again, same kind of idea, looking at lowest potency drugs such as clozaril and quetiapine. These are usually dosed in the hundreds of milligrams. Your medium potency drugs such as olanzapine and aripiprazole, which are going to be in the double digits, and then your high potency drugs such as risperidone, which are usually in single digit doses. All right, so looking at Clozaril, so Clozaril coming out in 1989, the first second generation antipsychotic. So interestingly, fairly low potency on the dopamine receptors, which is the real kind of conundrum about this medication is that it only has sort of moderate serotonin 2A blockade and fairly weak dopamine blockade, but yet is usually considered to be the most effective dopamine blocking antipsychotic medication, which is really, a bit of a conundrum I don't know how to solve for. The doses of this typically are in the hundreds of milligrams. It has significant antihistaminic side effects, which is what is going to account for some of its weight gain potential and also its sedation. It does have these acetylcholine muscarinic 1 receptor blockade, so we see these anticholinergic side effects. These can actually become, quite significant with this medication. Sometimes we can see paralytic ileus, and that can lead to some real serious complications. The upside to this is that we don't get a lot of extrapyramidal symptoms. There's also significant alpha 1 norepinephrine blockade. So this is what's going to account for the dizziness and sedation and orthostasis that we see with Clozaril. But yet, despite all this, it's still considered the most sort of effective second generation antipsychotic. Now, the reason why we don't use it as much as we might otherwise is because of this potential risk, something called agranulocytosis. So a loss of these white cells. And this happens in about 1% of people, but it can be fatal when it happens. And so there is something called a risk evaluation mitigation strategy, or REMS, that requires a couple of things. The provider has to register on the Clozaril REMS, and you need to check to see if the person has ever had an adverse reaction to Clozaril. Because if you discover a patient who ends up getting agranulocytosis, you're going to want to report that to the Clozaril REMS, so that if a future clinician goes to treat them with Clozaril, they'll find out that they've already had this side effect and avoid repeating that. And then we have to do blood draws weekly for the first 6 months, looking at the white count and the absolute neutrophil count. And then after the first 6 months, we have to do it every 2 weeks, and then we have to do it monthly from that point forward. And if we don't do this, we can't prescribe the medication. And so that limits the number of people that can really benefit from this medication, because they need to be organized enough to be able to get blood draws. And oftentimes, people with schizophrenia don't have that level of organization unless they're well supported. So if they have family member who is helping them, or if they are living in supported housing, or if they're in an inpatient setting, then oftentimes we can coordinate these blood draws so this medication can be used. But it does require a lot of monitoring. Additionally, we have to monitor for things like myocarditis and paralytic ileus. It can lower the seizure threshold. So there's some complications with using this medication, but in people that can avail themselves of it, it can often be very, very effective. One of the other things that it is known for is it's in that small club of medications in psychiatry that actually has a statistical reduction in suicide as a result of using this medication. So lithium and ketamine being the other two. So if you have a patient with schizophrenia who is experiencing suicidality, you also want to think about Clozaril. One sort of nuisance side effect is that it can cause a lot of drooling, especially at nighttime. People will just sort of soak their pillowcases with saliva, and you can sometimes use off-label ophthalmic atropine drops underneath the tongue to kind of dry out the mouth, and it's not systemically absorbed. So that's a little pro tip. Quetiapine was created along with olanzapine to try and kind of recreate some of the benefits of Clozaril without some of those agranulocytosis side effects. And so it is what's considered a low potency medication because the doses are typically in the hundreds of milligrams when used for schizophrenia. You may be familiar with using this in low doses for its sedating effects for sleep, but in schizophrenia, we're typically using this in doses in the several hundred milligrams. Also fairly weak dopamine blockade, so it just kind of drops by, sits on the little bus stop bench for a few minutes, and then moves on out. And it has moderate serotonin 2A blockade. It does have significant histamine blockade, which is what's going to cause the weight gain and the sedation that we see with this medication. And it also blocks alpha 1 receptors, the norepinephrine receptors. So we see those same dizziness and orthostasis problems that we see with many of these medications. Quetiapine, these lower doses commonly used for sleep, largely kind of leveraging its antihistamine effects. It's not ideal for sleep, but it can be useful if nothing else is working. But it typically does not have an antipsychotic effect at that dose. And then in bipolar depression, we can often get an antidepressant response with a dose of somewhere between like 150 and 300 milligrams. And so that's sort of the target for treating bipolar depression with this. And then in schizophrenia, we often have to go higher than that, often sort of in the 400 to 800 milligram range. Norquetiapine is its active metabolite, and that actually acts as a norepinephrine reuptake inhibitor and also activates serotonin 1A. So those are things that we associate with antidepressant response, which may be why quetiapine extended release has an FDA approval for the treatment of depression, augmentation of depression, which we'll talk about in a few minutes. But the weight gain and the sedation and the metabolic disturbances that we can see in this are somewhat limiting. And now it's a generic medication, so it's relatively cheap. One little pro tip that I'll share with you that I'll sometimes do if I'm trying to manage somebody who is developing mania and is usually a well-engaged patient. So, somebody who's had several episodes of bipolar illness and they come to you and they say, "Oh my gosh, I'm not sleeping. I feel kind of revved up and I know where this is going to go and it's not good." And they're not really at a place where they need to be psychiatrically hospitalized, but you really need to kind of shut this down. I have done this thing where I will say, here's some 50 milligrams, 50 milligram quetiapine tablets. I want you to take tonight, I want you to take, starting like 2 hours before bed, I want you to take one of them and I want you to take an additional one every hour until you fall asleep. And then tell me what that dose is. And, typically it's somewhere between 150 and maybe 300 milligrams. But that would be sort of the dose that I would use to help kind of cut that mania off, cut it off at the pass. And so that is something that you can do if you're trying to manage hypomania in an outpatient setting. Obviously, if it gets more severe than that, the person's probably going to need to be hospitalized. Aripiprazole is an interesting drug. It's a medium potency second generation antipsychotic, and it has this interesting mechanism of action because it primarily is a D2 blocker, as we see up here. So it has significant activity on D2, but it's also partially activating the D2 receptor. So it's kind of it's doing a little bit of both simultaneously, which is sort of confusing. Sometimes it's referred to as a dopamine stabilizer, but the idea here is that we are primarily blocking that D2 receptor, but we're allowing a little bit of activity, and perhaps this is what gives us some value in the treatment of depression, major depression augmentation, which we'll talk about when we get to mood disorders. So this is a drug that's really important to start low. And the reason for that is because if you start this at 20 milligrams or something like that, you're going to give people akathisia. So typically I will start this at 5 milligrams, or if somebody's really sensitive to akathisia, I'll do this at 2.5 milligrams and then go up until we get a clinical effect, until we start seeing a decrease in paranoia or a decrease in auditory hallucinations. Um, Yeah, so it does have sort of moderate antihistamine effects. So it's not totally devoid of weight gain. When this medication first came out back in like 2002, we were told that this was a antipsychotic that did not cause weight gain, which was a welcome thing to hear because all of the second generation antipsychotics, pretty much up till that point, with the exception of maybe ziprasidone, all showed significant weight gain. So this was didn't quite deliver on that promise. There is some weight gain with aripiprazole, but generally not as much as there is with, say, something like olanzapine. I mentioned the akathisia issue. This is a drug that has an approval for bipolar mania prevention, and we use it also in the treatment of major depression as an augmenter to traditional antidepressant medications. And that may be because of the serotonin 1A, the serotonin 2C. So the serotonin 2C is similar to mirtazapine, and then the serotonin transporter inhibition. So like a traditional SSRI may be what's contributing to that antidepressant effect of aripiprazole. Sometimes because of that peculiar activity on the dopamine 2 receptor, this is used in small doses and added to an existing dopamine blocking drug. So let's say somebody is on risperidone and they've developed hyperprolactinemia, and you don't want to take them off the risperidone because that's been working really well for them. You can sometimes add a little bit of aripiprazole and reverse that hyperprolactinemia, which is an interesting finding. And now that it's been around for a while, it's generic and cheap, and it comes in a couple of different long-acting injectable forms. There's Abilify Maintaina and aripiprazole. There's and Aristata is the other name for the two long-acting injectable forms of this. Other medium potency second generation antipsychotics would be things like olanzapine. And as I mentioned before, this was created to try and recreate the benefits of Clozaril without creating some of the same side effects, but has a lot of metabolic problems. So, you can see really robust weight gain with this medication, and you can see lipids get really dysregulated and blood sugar go up quickly. And it's an interesting drug too because the when people smoke when they're on it, it induces CYP1A2, and that actually causes the drug to leave the system more quickly, right? And so, not surprisingly, a lot of people with schizophrenia use tobacco. So what sometimes will happen is they go into a hospital where they're not allowed to use tobacco. They're put on something like olanzapine, they get better, and then they leave and they go back to smoking cigarettes. Well, that tobacco smoke is going to induce CYP1A2, which is going to cause that olanzapine to leave the system more quickly. That can cause the person to relapse. So it's just an interesting thing to think about when you think about the incidence of tobacco use in people with schizophrenia. Ziprasidone is probably an underappreciated medication, definitely more kind of weight neutral than some of its cousins from this era, and it has inhibition on the norepinephrine and serotonin transporters, so it probably has some of this antidepressant effects. There was concern when it first came out that it caused QT prolongation, but that has really been largely kind of put to bed. Lorazepam is a little newer. This came out about 15 years ago now, and also as I mentioned earlier, the later generation medications tend to be more metabolically neutral, and it also has a FDA approval for bipolar depression. Brexpiprazole, kind of interesting in that when it first came out, it was only approved for the augmentation of antidepressants. So while it has this dopamine blocking property of similar to aripiprazole, it actually had an FDA approval just for the treatment of depression. It's still on brand and still fairly expensive as the drug Rexulti. Lumateperone is the newest kid on the block. This is Caplyta, and this has an indication for both schizophrenia and bipolar depression. It's also weight neutral, but also quite expensive, and will be on brand and therefore expensive for quite some time still to go. All right, the high potency second generation antipsychotics are best represented by something like risperidone. So usually single digits. So you're looking at that strong dopamine blockade up there. Also strong serotonin 2A antagonism. Also has significant histamine blocking effects. So that causes a sedation weight gain. Also blocks norepinephrine alpha 1 receptors. So again, the same problems as dizziness and sedation and orthostasis. Um, and because it is so potent on those dopamine blocking, on those dopamine receptors for blocking them, it also has a tendency to cause hyperprolactinemia. So this is probably the drug of all the second generation antipsychotics, this and its cousin paliperidone, to cause hyperprolactinemia. So risperidone was actually made by Janssen, which is the same company that made haloperidol, and was intended to really be the second generation antipsychotic version of haloperidol. So similarly, it has that strong dopamine blockade, but it also has the 2A, serotonin 2A blockade that makes it a second generation antipsychotic. Haloperidol is its active metabolite that is sold as the drug Invega, which is one of the drugs that comes in a long-acting injectable form, as does risperidone. It comes in something called Risperdal Consta, which is a every 2-week injection. Not used so much these days because we now have longer-acting injectables that go for more than a couple of weeks, and we'll touch on those a little bit later. Other meds that belong in this high potency category would be paliperidone, that's known as Invega, as I mentioned. Interestingly, this is not a drug that goes through the liver, so you have a little more you have fewer drug interactions as a result of that. Iloperidone, not a drug that I've used a lot, but it's sort of known because it has strong alpha 1 noradrenergic blockade that it causes a lot of orthostasis and sedation. That's known as Fanapt and is still currently a brand only drug. Acenapine is Saffris. Curious that it comes in a sublingual formulation only, not a drug that I've really used much of. And cariprazine, which is the newer kid on the block. This is something that it has an indication for both bipolar mania and depression and schizophrenia. Because of its potency, it also has a tendency to cause akathisia, so a slow titration is needed for this medication. But the nice thing about it is it generally doesn't cause the same kind of metabolic problems that some of the older medications do. But it's also currently only available as a branded drug. Now, pimavanserin is an odd duck because I've told you all along here you got to block dopamine, right, to have an antipsychotic effect. Well, this is a drug that only blocks serotonin 2A. And it was developed because people with Parkinson's disease can develop psychosis symptoms. Now, that creates a real challenge for the clinician because you don't want to give somebody who has a illness that is marked by uh, decreased function of dopamine in the nigrostriatal tract a drug that's going to block those receptors. And so this drug was developed to only block serotonin 2A, and it turns out it has antipsychotic effects in people with Parkinson's disease. And the trials in schizophrenia were less promising. So it's a little bit of an odd drug with a very specific indication. So that's just something to know about. And I want to talk about things that may be coming out in the very near future, maybe even by the time you watch this talk, because this is in very late stage development. So if we go back and think about acetylcholine, so we haven't talked much about acetylcholine other than to think about side effects. And one of the side effects of blocking acetylcholine or creating anticholinergic side effects is that we impair cognition, which is really a problem in people that already have an illness that impairs cognition, and that would be the illness of schizophrenia. Remembering that acetylcholine arises from two different areas in the brain, so this basal forebrain, and also this pedunculopontine, ooh, that's a mouthful, nucleus. So right here on the top of the brainstem, at the pons, there's this laterodorsal tegmental nucleus that projects out into the cerebellum and down into the spinal cord. So we're going to come back to that in a second. So we remember that blocking these muscarinic acetylcholine receptors, causing anticholinergic side effects, will impair cognition. And that's really not great news because there's a group of people with schizophrenia that really have fewer muscarinic 1 receptors, okay, particularly in areas such as the brain, such as the hippocampus, which we need for things like memory and thinking clearly. And there's a group of people with schizophrenia that have just a decreased population of these. Now, so the idea of having a drug that might actually activate these receptors is intriguing. And then there's a second mechanism of action, which is also intriguing, but separate. And so this is where muscarinic activity has an influence on how much dopamine is actually released. So conceptually here, we're thinking about most of the time in schizophrenia and with dopamine blocking drugs, we are blocking the postsynaptic dopamine receptors. So the dopamine's flowing out, right? And we're just putting a lid over those receptors so it can't activate those postsynaptic receptors. What if we could decrease the amount of dopamine being released rather than block those dopamine receptors? And especially when we block dopamine receptors in areas that we don't want to block, really, like such as the nigrostriatal pathway or the tuboinfundibular tract, we cause those hyperprolactinemia problems, we cause those movement problems. What if we didn't have to do that? So that's really the question here. Could we manipulate these acetylcholine receptors in a way that actually turns down that dopamine release? So that's the idea with this drug here. So xanomeline troposium, which is currently known just by its sort of working title of CAR-XT, that's sort of reference to the company that makes it, Karuna, and XT for the letters for the first letter of the two drugs in the compound. Sorry, stumbling over my words here. So troposium is actually a anticholinergic drug that can't cross the blood-brain barrier. Because think about it, if we activate the acetylcholine receptors in the whole body, okay, we're going to cause a lot of GI side effects. So we're going to tend to cause like nausea and vomiting. So troposium is there just to counter out the fact that we are activating acetylcholine receptors. And xanomeline can cross the blood-brain barrier. Troposium cannot. Okay, so troposium and xanomeline are going to kind of fight it out in the rest of the body because obviously the drug goes everywhere in the body. But the idea is that troposium there to kind of limit the deleterious side effects of a procholinergic med in the area outside of the blood-brain barrier. Xanomeline is going to cross the blood-brain barrier with the intention of limiting dopamine release. And let's talk about how that works. So in psychosis, so remembering here, let's walk through this little schematic here. So this purple line here is a GABA interneuron. So remember those GABA interneurons, they synapse onto other neurons and they kind of put the brakes on, right? So in this case, this GABA interneuron in psychosis is synapsing to a glutamate interneuron. So we've got, this is kind of putting the brakes on this glutamate excitatory neuron, right? This is in the frontal cortex, and this is synapsing to the ventral tegmental area and the nucleus accumbens. These are two key areas of the mesolimbic psychosis pathway. And what's happening here is that in psychosis, oh, and I also just want to point out, because this is kind of a preview of coming attractions, that there is a muscarinic 1 receptor here. So in this case, what's happening is that this is not really putting the brakes on the glutamate. Okay, so we've got kind of a small circle here indicating kind of the amount of inhibition that's happening on this glutamatergic interneuron. And what's happening is it's allowing this glutamatergic interneuron to activate the dopamine neuron. So remember, these glutamate neurons excite other processes. So in this case, it's exciting this dopaminergic neuron, which is causing more dopamine release. Okay, so this is the idea, particularly in areas of the brain that are associated with psychosis, such as the nucleus accumbens. Now, let's introduce this, what happens when we activate. So this M1 drug, this CAR-XT, is going to activate this M1 receptor. That's going to make this GABA interneuron work better. It's going to put more of an inhibitory signal out to this glutamate interneuron. So it's going to say, hey, glutamate, don't release so much glutamate downstream. Put the brakes on. Okay. What's going to happen there? So now that that glutamate interneuron is not going to excite this dopamine neuron so much. What does that mean? Less dopamine gets released in the nucleus accumbens, which is where we see psychosis symptoms arising from. So we're kind of putting the brakes on the dopamine release downstream by activating this muscarinic receptor way upstream here. So super interesting mechanism of action. Be interesting to see where it goes. Not FDA approved yet, but certainly something to keep a close eye on. Definitely had some efficacy. So in this thing called the PANS, which is the positive and negative symptom scale, almost a 10-point reduction, which gives it a Cohen's d was calculated at about 0.6. So if you remember back to effect sizes from the first week, we talked about the Cohen's d when it's around 0.6, 0.7 being a moderate effect. Usually above 0.7 is considered a large effect. So nothing to sneeze at here. Um, and and if we look at the side effects, we don't see increases in weight. We don't see increases in prolactin. We don't see akathisia. So great. None of those things that go along with dopamine blockade where we don't want it. What we do see is an increase in these kind of GI side effects. So we see more stomach issues. We see more vomiting. We see constipation at a higher rate in the drug group than we do in the placebo group. So I think the trade-off here is we're not going to get some of those movement and weight gain issues, but we may see intolerable GI issues with this medication, which is coming from the xanomeline triggering those bodily acetylcholine receptors because it's procholinergic. Okay, so what's the best one to use? Well, this Katie trial was interesting because it really showed that the medications are all roughly effective, with the exception of clozaril. So if we look at this forest plot here, remember how to read these things. The more over to the left here this is superior to the drug, right? So all these are effective because they're all better than zero, right? But if we take a look at the average, that's that black square, the mean score, they're all roughly about the same, except for clozaril, which really stands out head and shoulders above the rest. So what this means is it's kind of like when we think about the antidepressant medications. There isn't one clear winner. We think about what's worked for the patient and what side effects might be useful in a particular patient, or what's going to make it so that if there's something they say, I'm not going to take a medication that's going to make me sleepy, I would certainly not use clozaril or chlorpromazine or any of these medications that are on the bottom half of the list here. If they say, I'm not going to take something that's going to cause weight gain, I would not use olanzapine or clozaril or chlorpromazine again. So these are the kind of things that we want to think about when we're thinking about a drug. If we need something that we know is going to work, clozaril would be the way to go, right? Olanzapine. This is why olanzapine still gets used so much because it's pretty darn effective. The downside is it causes a lot of side effects. Whereas a medication down here may not be as effective, something like ziprasidone, but is probably going to be more tolerable. So again, it's this art to this kind of practice. But really, the best antipsychotic for a patient is the one that they will actually take and that will help them feel better and more importantly, to function better. All right, so that's the end of second generation antipsychotics. In the last section, we'll talk about how we use these things in the treatment of mood disorders such as bipolar disorder and major depressive disorder. Thanks.